morning, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today I'd like to have a conversation with Dr. Jay Fisher. Dr. Jay Fisher, put it simply, is someone I consider one of the forefathers of pediatric emergency medicine in the US or maybe even in the world. He is someone that I've known for several years who have done a lot for the field of pediatric emergency medicine in the US. And today we're going to talk about pediatric emergency medicine, past, present, and maybe future. Good morning, Jay. Let me just introduce you to the listeners, and you're gonna have to help me, Jay, a little bit. So Jay grew up in, and Jay, please forgive me, I cannot possibly pronounce that town you grew up in.
Pawtucket, Rhode Island, yeah.
Pawtucket, sorry, with the W there, it throws me off. So Jay grew up in Pawtucket, Rhode Island, went to medical school at Brown University. He then completed his pediatric residency in general pediatrics at Boston City at Boston University, which I believe is now called BMC, Boston Medical Center. I went to college at Northeastern down the road. And then his PEM fellowship, also at Boston City in the same institution. He has worked at Children's Hospital of Nevada for 29 years, was also the medical director there, and founded the Pediatric Emergency Medicine Fellowship with a grant from the state of Nevada. And that fellowship is 2 years old. Jay, is that right?
Yes, the third class is working through it right now. Yeah.
Very nice. So thank you, Jay, for coming on the show. I really appreciate it. And the first question I ask Jay, and it's a question I ask all my guests on the show, is, you've been a PEM doctor for many, many years. What do you think, or what is your ideal PEM physician? One who does what?
That was a great question, and it's hard to answer a little bit because there's so much that we're asked to do. But I guess I would say one that has four things. They care for patients carefully and efficiently. They continuously learn from their patient outcomes. They follow up on their patients and learn. They remain insightful about what our profession really knows and also what they know in reality. Mm-hmm. And one that continuously examines research and dogma carefully.
Okay. And among those four, what would you say is like the most important one?
Yeah, it's interesting when I read this now, because you asked me this before, but I would say the first one, with being careful and efficient, but then also at the same time, which is the challenge of our job, of course, is just, that once a month thing where you got to just, stick your chin out and be the leader and get everybody on board and say, let's save this kid's life,
Sure. Now, the second question, Jay, as someone who worked in this field for so many years, I'm sure you've seen that the PEM field going through some significant changes. How would you compare it back to when you started? When did you graduate your fellowship?
1992.
1992. So how would you compare the field of pediatric emergency medicine from 1992 to today?
Yeah, and I answered this. I always get philosophical. I apologize for that.
So please get as philosophical as you wish.
Well, I mean, I think there's two paths I would answer this question. One is philosophically, in that I think that the job has changed a lot, in that the accountability and expectations that we all are expected to have and maintain are dramatically higher. I was kind of in that last gasp of the old doctor class, and we just did what we said we were going to do, and malpractice was just kind of starting. And so now 30 years later, the expectations and accountability are quite impressive. That's philosophically one thing. Secondly, the job has been monetized to a level that impacts everything that we do, and the productivity and efficiency part of the job has to really be taken into consideration at all times. So this has created this fundamental conflict for physicians, where now young physicians have to be, sign on to never make another mistake in their life, and also see 1 million patients. And so that's one pathway that I see my own children and my own partners, struggle with daily, is just the new physician. It's an incredibly difficult job. And then I would say specifically to the practice of pediatric emergency medicine, there's a lot of changes as well. The baseline set of knowledge that a PEM doctor these days has coming out of training compared to what I had is impressive. I look at, for example, Dr. I think it's Mike Mojica in New York, who, it's his hobby is to publish a new edition of his book online every month.
Which is a very, very good resource that I use all the time.
Yeah, I do too. And so, and the breadth of that document is just astounding. And, in my day, it was, if you could retain information really well in your brain, you were really the cool doc. Now everyone's like, it's not about that because you got it on your Google phone in 20 seconds and everyone knows how to access it way faster than I'll ever be able to retain it. And so that's not the cool thing anymore. The cool thing now is to be the guy with the big toolbox. And that's why I started having some trouble in my fellowship. When I was doing the fellowship, I was like, man, I'm not sure I'm the right guy to teach this anymore, because their toolboxes, like within a year of them starting, their toolboxes were bigger than mine, and they were impressive. So I would say those are some areas, and also maybe the integration of different specialties. That it was I know it doesn't feel this way perhaps, but the field was much more siloed back then than it is now. I just retook ATLS because mine expired, and the interface we have now with trauma surgeons and all that they bring to the table about hemorrhage control and identifying hemorrhage. I don't know. It's grown a lot more. I think about it.
Yeah, I'm listening to you, and I don't know how this field started, because in 1992 I think I was in middle school, but I certainly I understand exactly what you're talking about. Specifically with the last point, I couldn't agree more. It's not about knowing the information; it's about knowing where to find it. So I go up to date on Michael Mojica's PEM resource all the time, and I see the residents. The residents are very good in doing this. They know where to find MedCalc and how to get on it and what's available on it. And yeah, I couldn't agree more. You don't need to know a whole lot. You just need to know where to find the information. I couldn't agree more.
Yeah, I'll give you an example of that. I mentioned my daughter, the pediatric nurse practitioner, a new one, just out of training, and we were chatting. We chat about cases every couple of days, and she was mentioning we had a case in Nevada. Not so long. There's a lot of cases of botulism, and she just quipped back at me, "Oh yeah, so they sent him to the CHLA to get some big, right?" And I'm like, "How did you know that?" When I was a first year practitioner, I would not have known how to either diagnose or treat botulism. And so they have a big fund of knowledge coming out of training. And so I'll give you a little history. When I started PEM, I think I was about the first boards were 92. I missed the first round of boards, but I took the 94 boards. And so, it was people in the Northeast, Gary Fleischer and Dr. Ludwig and many others who saw that, the field started in the early 80s when they realized they were pediatricians working in residencies in the Northeast, and they were moonlighting in ERs to make a buck. And they were like, wow, these ERs at this time really aren't prepared for children. And so that was the start of PEM. And then it very quickly in the late 80s evolved into a complete mastery of fever. And then stable. And then so in the late 90s is late 80s, is when all the fever research came out. And a lot of the very nascent pediatric resuscitation courses. I took actually the very first, I think it was the first old-fashioned APLS course in Boston back in the late 80s. And so the whole notion of resuscitation standardization was coming on board. So in 1992, you just were kind of the doc that had the mastery of fever, mastery of sepsis, knew about resuscitation, knew some basic procedures, and that's kind of what you came out of school with, And then, but it's changed a lot.
Yeah. No, what I love hearing from physicians from your generation, and I know Dr. Rick Saladino, who trained me in Pittsburgh and trained at the same time with you in Boston, and Dr. Bob Hickey. What I love hearing from you guys is what fever meant back then in the 90s, before PCV13 and the Haemophilus influenza vaccine, where kids truly got septic and kids truly got bacterial meningitis, which is something I essentially never seen except for GBS, or maybe I've seen once, and how incredibly common those conditions were back then. You guys were real pediatric emergency doctors. You guys treated seriously sick kids. It's amazing.
Yeah, there's been so many changes along the way. The impact of surfactant on the PEM doctor is impressive as well, because we say, well, what are you talking about, Jay? How did surfactant change PEM medicine? Well, in the 80s, there was no surfactant, and every 28-week or 26-weeker was on standard ventilation and high pressures, and they had massive intracranial bleeding, which resulted in strokes and bad brains and tracheostomies and chronic lung disease. And so we saw so many kids that came in status and complications of their ICP at 6 months and 8 months or whatever, with shunts that needed revision. That infant population was a lot less healthy than it is now as well. So that I could really see it, that where all of a sudden, about in the late 90s, I'm like, where's all those kids that with chronic lung disease that we used to see, that used to come in and you just couldn't ventilate them? They would come in seizing, and you're like, oh my God, I cannot ventilate this kid. And it was terrifying. We still see that, of course, but it's just not as frequent. Yeah.
Sure.
So that was changed. And then, the infection thing was definitely a big deal. I mean, every otitis media was the harbinger of meningitis, and the PEDS ID people at BU are just apoplectic if you didn't bring down your bulb and insufflator to check every kid for otitis media, because if you miss that, then they're going to come back in 36 hours with pneumococcal meningitis. Wow. So it was a different time, and but honestly, now there's a lot of there's complexity as well that I think the current PEM docs have to deal with. So there's always something.
Sure. There's always something we deal with.
Yep.
Jade, so those are really great points. My last question to you, and I think that question specifically, I'm very happy that you are here to answer it. You've been probably an instrumental part of many trainees, mostly ED residents, pediatric residents, family medicine residents that have worked with you in the PGR. And I work with a lot of trainees, and I know a lot of trainees, a lot of medical students listen to my podcast, a lot of residents. My last question to you is, what advice would you give someone who is thinking of going for a PEM fellowship or practicing pediatric emergency medicine these days?
To absolutely do it.
Okay. Well, I hope you give that advice. That's good.
Yeah, I mean, here I am at my age, and I still don't feel like I'm the master. And isn't that grand, right? That I can practice something for 30 years and have a fire in my belly to say, I want to be better at this, because it's that hard. Because it's, I want to have that perfect shift. And so if you can get a job that pays you, and that each and every, and still it gives you a chance to do something really meaningful and impactful, and give kindness to people, and then to say, I still want to know that coagulation cascade better. I still want to know how to identify sepsis better. It's a passion. It changes your life. It becomes who you are. And that's what it did for me. And I know Dr. Saladino, he was one of my mentors, and he did it for him. And I never want for purpose in my life, and it's great. And I think I think I'm worried about PEM now, and I'm worried about medicine in general, because I think we need to be more benevolent with our trainees. I just think that they need more kindness and more, forgiveness and understanding. I think they're all like walking on a high wire, and I just, I know you're a musician, and I thought of this line from Bob Dylan, was one of my favorite artists as well. And he said, I offered up my innocence, and in return got scorn. And I think sometimes I see the trainees, and I'm like, that's quite what they're doing, is they're offering up their innocence to us. to step up to this challenge of peds emergency medicine, and sometimes we don't throw them a bone. So, yeah, so go into PEM definitely, and help those people offering up their innocence for the next generation, and just keep at it.
Very nice. Inspiring words indeed. Jay, one last question.
Yeah.
And I know you're familiar with the podcast. I'm very grateful that you've been listening. And I know, as we spoke, that you know Dr. Rick Saladino, who's the inspiration behind this podcast with PEM rule number 1. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. And him and my mentors in Pittsburgh taught me many other rules. I always ask my guests, and as an experienced PEM provider, do you have any rule that you have followed in your career that you can share with us?
I've accumulated one and that is that when you're blasting through, 30 kids with fever in a given in one of these viral waves or whatever, if three things come to the tip of your tongue that are bugging you, and these three things can be anything from just a level of activity, or a rash you can't characterize, or a mother that you can't communicate well with. If there's three things that line up that just make you nudge a little bit, do something more. That's helped me a couple times. That's really saved me a few times.
Okay. Can you give us an example?
Yeah, this is a case I always refer to that I still to this day can't completely wrap my head around. But I had a little girl who was referred to me by a peds nurse practitioner, a pediatric practice that used peds nurse practitioners, and they had a reputation for referring too much to us, which of course is what all PEDs say, right? Is that these practices refer too much. But listen to this story. This peds nurse practitioner referred this patient to me. It was like a Monday morning in June, and she said, "I'm going to send you a patient with headache and fever. She's 7 years old. I think she has meningitis." And I said, "Oh, okay." I was like, because like you said, we don't see much meningitis anymore.
Right.
I said, maybe she means viral meningitis. And I said, "Yeah, go ahead, send her." Yeah, okay. So that's one strike to me. You got another provider who says meningitis.
Right. The bad word.
Huh? Bad word.
It's a very bad word.
Yes. So that's strike one. So she walks through the door. I can see her walking through the door of the ER, and she looks fine. She's got a dolly in her hand. Her father's walking with her. She didn't have meningismus. She didn't have photophobia. She had fever and tachycardia, and she had fever and headache for 4 days. And the only thing about her was that when I put her down to do Koenig and Brzezinski, she winced in a funny way. She kind of shrugged her shoulders and winced. But I would say she had a negative Koenig Brzezinski. She did not have a stiff neck. And the resident that saw her before me said, I think she's got viral meningitis. It's June. Let's give her some Toradol and fluids and Zofran and call it a day. So I said, all right. Well, I did this when I had the wince thing in my exam. I'm like, no, we're going to help here. And the resident was like, "No, come on, it's viral meningitis. She'll be fine." Well, the white count came back at 16. I walked back in the room. She's gotten Toradol and Zofran. I kid you not, Yaron. She's playing My Pretty Pony cartoon on the TV. She's coloring in her coloring book. And now the dad wants to go home because the kid's better. The resident said that she's okay. And I said, "No, I put my big boy pants on and I said, no, we're going to help you, Dad. I'm sorry." And we did. She had pneumococcal meningitis. Wow. So, yeah. So the three things that were there were, number one, the nurse practitioner said meningitis. Two, this funny wince of her neck when I laid her down, she just kind of winced and shrugged her shoulders. And number three, the white count maybe, or something like that. Or maybe number three, that the resident wanted to send the kid home, or whatever the case may be. So I'm not sure that case is I'm not sure I just didn't get lucky there. Maybe it's just luck. And I've done some consulting for at times and for defense attorneys, and I see some of these cases around the country that don't look too dissimilar to this one, because I've published this case and talked about it. So I try to help other doctors that get into a jam with these kind of cases. And sometimes you have to be lucky, and because maybe I don't know. But that case to me said, that was the origin of my 3-strike rule, and I've used it since then, and it's worked several times. And I actually got a text from a resident not too long ago saying, "Hey, Fisher, I used your 3-strike rule the other day, and the kid had meningitis." And I'm like, "Oh, there you go."
Yeah. No, so I think that's a good rule. My fellowship director, Dr. Noel Spears, phrases it as 3 strikes, you're out. So 3 strikes, I'm doing something about this. So I guess it's kind of along the same line.
Yeah.
And I think that, I mean, that's a
Right.
kind of a scary story, but a very good story with a very good lesson. Yeah.
Yeah, I mean, sometimes in medicine it does pay to be more lucky than good.
Sure.
And sometimes you can be a perfect doctor. I've run codes perfectly and the child has died. I've run codes not so great and the child has lived. So it's not a straight line.
Sure. Absolutely. Jay, again, I can't thank you enough for coming on the show. I really appreciate it. I think my listeners will benefit tremendously from your wisdom. I do have a habit or a custom that I do on the podcast, and I always try to honor my guest with an outro of their choice. I know, I don't remember how. I think back then when I met you in 2016, that you are a very big fan of AC/DC. Is that right?
That's right.
That's right. All right. So I got to be honest, not exactly my cup of tea, but in your honor, I'm going to try to do Back in Black by AC/DC. I hope you like it.
All right, sounds good.
Sounds good.
Keep up the great work, Yaron. I love this podcast. Good work.
I appreciate it. You know, coming from you, I truly appreciate it, and I'm honored. Thanks again for your time, and keep up the great work. It's amazing.